Hi, everyone. I'm Inga Lennes. I am the Senior Vice President for Ambulatory Operations and Patient Experience here in the MGPO. And this is our Two Things series. And I'm really pleased today to have with us the Director of Primary Care, Michelle Leroux. So welcome, Michelle. Thanks for joining us for this conversation today.
Thank you, Inga. I'm happy to be here.
Super. Well, why don't we start off? I want to ask you about the COVID response in primary care specifically and how that's going, and if you want to tell us and the people watching anything about that.
Yeah, no, I'd be happy to. I mean, I must say, I am so incredibly proud to be part of primary care during this whole COVID pandemic. They truly, every member of our team has really been at the forefront, as you know, with RICS and with the inpatient surge teams. And obviously in our practices. I mean, I would say the second go round in our surge, the practices are really feeling a bit different impact this time. The opportunities are great. You know, we have vaccines, we have monoclonal antibody therapies, but it really comes to primary care where the questions from patients and wondering, you know, what's next? How do I receive this? And for the teams, when is it appropriate? So I would love to ask you, because I know you're probably hearing it, and we're definitely hearing it from our practices. When would you expect, or what is the plan for our patients regarding the COVID vaccine?
So it's a great question, and there's a lot of planning that's started. I will say that one of the key elements that we are still waiting to confirm is the date that we will start vaccinating patients, but we're getting closer every day. Our emergency response team and our disaster preparedness team are working really closely with the state, and I will say that it should be coming soon. I don't want to say exactly the date, but I think we're going to get that information very soon. And then additionally, we're starting to work on all of the logistics. So, and we'll be engaging with leadership across the organization as well as at MGB to really think about this. Part of how we design the operations depends on the type of vaccine. Some vaccines require different storage requirements, and so that's going to be a big factor. And then also, we're waiting for the state's guidance on exactly what the phases will be and who should be prioritized in each phase. And there's been a lot of discussion through the leadership groups at the state about the phasing of vaccination. So we'll take that guidance and translate it into a plan for patients both at MGB and at MGH. So I know that's a little bit of a non-answer, but I do want to tell you that it's coming. One thing I have heard is the amount of communication that our patients are asking for around vaccines. And I know myself in my clinic, every patient is asking about vaccinations, and I know that we're getting crushed with calls. So communications are coming, both at the MGB level, and we're going to be working on MGH communications to patients to tell them more about the planning effort and to reassure them, hopefully to cut down on some of the extraneous calls and that I know that everyone is dealing with. So more to come. It's definitely a priority for us, and I know it's a priority at MGB as well.
That will be great, and really appreciated, I'm sure, by the practices, because you're right. I mean, they're getting patient gateway messages, they're getting phone calls. So I think the messaging and the communication to patients will be key. I was hoping I could ask you as well about, you know, the monoclonal antibody therapies that have been available through, I know, the lottery system, but also now we have access to the CVS home infusion. I wondered if you could speak a bit to that, because primary care physicians are definitely wondering about that and want to learn more so that they can offer it when it's appropriate for their patients.
Great, thank you for asking that. So yes, since early December, we have had I would call it a pilot program where we have automatically captured the patients within MGB that were tested within MGB who met criteria by age, being 65 or older, or BMI of 35 or greater. Those patients were put into a pool and were contacted by a clinician that we had put together, an ad hoc group of clinicians from across MGB that did this work specifically they called patients and discussed the opportunity for monoclonal antibody therapy given either at MGH or the Brigham. And if the patient assented to the treatment, then they were booked for infusion. I will say also that there was a lottery. So to create the list of who was called, the eligible patients went into a lottery, really mindful of equity to make sure that we weren't giving all of this scarce resource to a more advantaged group of people. So, and it was fair. One thing that we learned by doing this is that patients really depend on their primary providers. And when sort of a stranger calls them to offer the therapy under an EUA, it can be a long conversation, and there's things that they would like to discuss with their primary providers. So we looked at models across the state and saw that other people had been doing this successfully by allowing referrals by primary care doctors or other primary providers for this service. So an EPIC referral was created and was debuted yesterday. There was a clinical update that came from the MGPO on the 5th of January, and we will send it again, that it outlines the availability of this EPIC referral, which now allows any provider to place a referral for an eligible patient who meets our eligibility criteria. Once that referral is placed, the patient goes into a lottery. So it's not a guarantee that the patient will get the therapy, but what it does is that it puts the shared decision-making in the hands of a provider who knows the patient and then can skip over that process of having to have someone call them. So it kind of moves you up in line to the lottery, so we don't have to wait for a phone call. The other thing that's really hard about this is time is of the essence. So the drug is most effective if it's given early to ambulatory symptomatic patients. And so we really want the requirement of the treatment is that we're making these referrals within the first 72 hours after the test comes back positive. So it's a tricky operational issue, but we think that involving more caregivers in the ability to make these referrals will allow us to fill up our capacity a bit better. The other thing that you mentioned is that this particular therapy, the bamlanivimab monoclonal antibody therapy, is currently being given by CVS as a home infusion. And so that Quorum CVS program isn't administered by MGB, and I get questions whether it's an MGB or MGH program, and it is not. It's a CVS Quorum program. But we as providers, as all providers in the state, have the ability to refer patients for this home therapy. It's nice because from a patient experience perspective, it's very nice to have someone come to your home to give this therapy. And we're not exposing anyone else to a COVID positive patient coming into our care areas. The hard part is that there are lots of people, including probably some primary care doctors, who aren't used to writing for infusional therapy. So it's a new workflow for us, and we are working with CVS to make it as seamless as possible, as seamless as possible. So you'll see in the communications that we have linked the CVS referral form and the orders for the drug. So in the CVS program, the person who is referring the patient for therapy is also ordering the actual drug and the medications for anaphylaxis if needed in the home, which would be kind of a standard infusional care pack that goes with an infusional therapy. So we just are really working on trying to get education out to make more providers comfortable with that. And to that end, we have scheduled an information session tomorrow on Thursday at 1:00. It'll be a virtual information session, and Dr. Hammond from ID and Dr. Rubin from Pulmonary Critical Care will be there with us to discuss the shared decision making. So really to help make clinicians more comfortable with that discussion, discussing the risks and benefits, possible benefits of this infusion therapy, and then making people feel more comfortable with the order set and the orders that go along with it. So we'll be recording that as well and making it available after the fact. So you don't have to worry about signing up for it live. So those are the things that we're doing to try and help. I would say one last thing is that We're looking into another infusion company, New England Life Care, who works with us specifically to see if that could be another avenue for home infusion. But instead of using the CVS supply, they'd be using our own supply. So to save our infusion chair space for medical and cancer infusions that normally take place in the areas that are currently doing this infusion. So lots more to come with monoclonal antibody therapy, and that was a mouthful, but thanks for asking, and definitely check out the virtual training tomorrow.
That's wonderful. Thank you.
Okay. Well, I want to take this opportunity to thank everyone, including and especially our primary care colleagues, for their amazing work. Everyone is working really hard. I know how much the primary care doctors are really devoting to patients and the difficulty of the job that they're doing, sort of handling all of the competing interests of patients and COVID. So thank you, Michelle. Thank you to everyone in the urgent care, the RICs, who are doing that work. Everyone stay safe and sign yourself up for the vaccine if you haven't already, and be hopeful in the new year. Happy New Year, everyone.